A very good morning, dear friends. I am Dr. Sambit, endocrinologist from Bhubaneswar. I'll be discussing on understanding the scale of problem, the devious duology of diabetes and obesity. Friend, as you all know that diabetes and obesity are in a sync actually. We call it as the syndemic because as you see the years passing, you can see that the prevalence of diabetes is increasing and so is the prevalence of obesity, and they have exact wave or the trend by which they grow. So that's what they are known as, the two epidemics in one grow. So they are known as the syndemic, so diabetes and obesity. And both the things are very bad to the individual if they have both. And 88% of people with overweight and obesity are diagnosed with type 2 diabetes, and out of all the people living with diabetes, 77% of this individual may not achieve the target. And we know, as per the ADA standards of care, our own RSSDI clinical practice guidelines, the cutoff of HbA1c of less than 7 has been known as a good glycemic control. But unfortunately, 77% of this individual do not achieve the target. I was talking about the syndemic or the surging syndemic of diabetes and obesity, and you can see that 8 of 10 people with diabetes can have actually overweight or obesity, and 1 of 3 individual who are having overweight and obesity can ultimately land up in the deadly disease known as the diabetes. And we all know that as the weight increases, the chances of obesity also increases, or the as the obesity increases, the chances of diabetes also increases. And this is a very excellent study by Yu et al, where they have shown that if the prevalence of diabetes in a normal weight individual, we can tell it as one-fold, it increases by almost 2.24 fold in patients who are overweight. In population who are obese, the chances of developing diabetes can go up to 4.5 fold, and those with severe obesity, the chance of developing diabetes can be of 22.9 fold. So almost a 23 fold increased risk of developing diabetes if the person is having severe obesity. So there is also a concept of normal weight obesity, and we have been talking it quite for a few years down the line. So that's known as normal weight obesity, and especially population in the Southeast Asia and in the Indian population, there is a variant known as the thin fat Indians. So thin fat Indians means though the BMI is not high, but still the adiposopathy is quite high. So the adipose tissue uh, is high even at the same BMI, and the distribution of the adipose tissue is also abnormal in this individual because more of fat is being deposited in the visceral portion, and we can detect from the waist circumference the visceral adiposity is quite high. So even if the BMI of an Indian person may not be that high as that of the Western population, but still they have all the problems of obesity because the adipose tissue is high and they are abnormally distributed in the visceral tissue. So that's why known as the thin fat Indians. 32% of Indians have normal weight obesity, and since the visceral fat is the primary modus operandi for developing all sorts of inflammation, the obesity related comorbidities, diabetes, hypertension, dyslipidemia. So more chance of developing diabetes, hypertension and dyslipidemia in this group of normal weight obesity. Now there is a very excellent article also that has shown that as the BMI increases, the diabetes related healthcare cost also increases. For example, if the person is overweight, then there is a direct cost of diabetes increases by plus 11%. If the obesity class 1, that means if the BMI is between 30 to 35%, there is a 17% increase in the cost. And in class 2 obesity, if the BMI is between 35 to 40, the cost for diabetes management increases by 29%. And if the obesity is class 3, that means more than 40 kg per meter square is the BMI, then there is a plus 46% increase in the direct cost. So if a person is having diabetes and also obesity, according to the extent of the obesity, the cost of treatment also increases. So obesity not only gives you a bad looks to some extent, it can actually weigh more to your pocket. So it also increases the cost of the therapy. I was discussing about the syndemic of diabetes and obesity. Now, both the diseases actually affect each other, and there is a vicious cycle to that. So, for example, if the person is having overweight or obesity, there are challenges in the food, there are challenges in the physical activity, there would be sleep disorders, there would be inability to be active all the time, there would be stigmatization also. So for that reason the person may not go for regular physical activity also. And there are some social isolation, there would be violence, there would be income inequality in the office or in the workplace. So all this factor increases the stress, and as we all know that if the stress increases, there are more chances of diabetes. And finally, adiposopathy can actually lead to beta cell dysfunction and also insulin resistance, and that both can lead to diabetes. The reverse is also true. If someone is having diabetes, they can have poor outcome in terms of the obesity, because there are drugs which we use in diabetes, for example, sulfonylurea, to some extent to some insulin, some pioglitazone, that can actually increase the weight of the individual. There are neuropathy with diabetes, and that may preclude the person from going into regular exercises. Hypoglycemia, if a person with diabetes develops, then there would be rebound increase in the hunger, and the person will compensatory take more carbs and more food to prevent hypoglycemia, and that can also lead to increase in the weight. Stigma and impaired mental health is also another factor that can adversely affect obesity. So both the components or the syndemic, like diabetes and obesity, can adversely affect each other. Now there are studies which have shown that greater the weight loss, greater is the improvement in the overall health implication. So even if you are losing less than 5% weight, 5 to 10% weight, 10 to 15% weight, or more than 15% weight, at each level you are actually giving some advantages to your patient. For example, if someone is losing 0 to 5% of the body weight, the glycemic control can significantly improve, the hypertension can improve. If someone is losing 5 to 10% of the body weight, there would be prevention of type 2 diabetes. That means someone is going from pre-diabetes to diabetes may not happen. NAFLD, obstructive sleep apnea, PCOS can improve. If if we have a weight loss of 10 to 15% in our patients, then the cardiovascular disease risk will substantially go down, the urinary incontinence will improve, the obstructive sleep apnea will improve, the gastroesophageal reflux disease will improve, and the mechanical things like osteoarthritis will also improve. And if someone is losing more than 15% of the body weight, then there are sufficient evidences like the study by Dr. Roy Taylor, where they've shown that if a person is losing more than 15%, there are chances of diabetes remission also. CV mortality significantly reduced, and heart failure with preserved ejection fraction can also improve. So at each spectrum of the weight loss, the a person with diabetes can actually have some risk factor or some comorbidities that is improving. So at least we should try the patient to lose weight so that the diabetes complications and the other comorbidities will improve. So weight loss reduces the risk of development of type 2 diabetes, and in this study you can see that weight reduction of every 1 kg can actually reduce the risk of diabetes by almost like 16%. And if we are losing weight for a diabetic patient, the HbA1c not only goes down exponentially down, the fasting plasma glucose and also the postprandial blood glucose will also go down. So before ending, I'll just want to take you across two important trial which has shown the reduction of the blood pressure or reduction of the weight can actually have got various good implication in terms of the outcome in patients with type 2 diabetes. So for example, the look ahead trial, where the benefits of 10% weight loss can be significantly seen in terms of the primary composite cardiovascular outcome, where they have taken as CV death, non-fatal MI, non-fatal stroke, and admission to hospital with angina, and also the secondary outcome has been significantly reduced with 10% of weight loss. We have also just wanted to highlight the important trial by Roy Taylor, that is the direct trial, where that's the diabetes remission clinical trial, where they have shown that with reduction of the weight, less than 5 kg, 5 to 10 kg, less than 15 kg, and more than 15 kg, you can see that there are chances of diabetes remission. And if the person is actually doing more than 15 kg of weight loss, then over 1 year there would be 86.1% diabetes remission, and over 2 years that can be up to 70% of diabetes remission. So Leucide trial has clearly shown that weight loss is probably the important factor in prevention of diabetes and also in diabetes remission. Targeted approach to weight management in type 2 diabetes, we must target at least 5 to 15% weight loss in patients with type 2 diabetes to reap the beneficial effect, like improve the cardiometabolic risk, improve the metabolism, disease modifying effect, and improve the quality of life. And this is the American Diabetes Association 2023 guidelines, and clearly it has shown that use of glucose lowering drugs has to be related to cardiorenal beneficial effect, especially in patients with severe risk factor, and also weight reduction is an important component. So if the person is having heart failure, chronic kidney disease, established cardiovascular disease, or risk factor of CVD, a GLP-1 receptor agonist with proven cardiovascular safety or an SGLT2 inhibitor independent of background of metformin can be initiated. And when choosing a glucose lowering therapy, choose the regimen with high to very high dual weight reduction and also blood glucose reduction potential, for example like a GLP-1 receptor agonist with proven effect like semaglutide.